Today we'll be starting with myopia, which is one of the refractive errors. So before we do, we should know what is emetropia and what is ametropia. So what do you call as emetropia? That is a normal person who's not having any refractive error. So what is emetropia? It is a state of refraction wherein the parallel rays of light coming from infinity are focused on the sensitive layer of retina with accommodation being at rest. Then what is ametropia? When the parallel rays of light coming from infinity, they are focused either in front or behind the retina. So the types of ametropias are myopia, hypermetropia, and astigmatism. So now what is myopia or short-sightedness? This is the type of refractive error in which the parallel rays of light coming from infinity are focused in front of the sensitive layer of retina with accommodation being at rest. So what is the etiological classification? Myopia can be axial, curvatural, positional, index, and myopia due to excessive accommodation. So what is an axial myopia? It is because of increase in the anteroposterior length of the eyeball. So what is a normal AP length? It is 24 millimeters. So if the length of the eyeball increases more than that, the patient is going to have myopia because length of eyeball बढ़ गया. So the rays of light will be focused in front. Then what is curvatural myopia? It is because of increase in the curvature of cornea, lens, or both. Positional myopia, it is because of anterior placement of the crystalline lens. Because if the crystalline lens gets placed anteriorly, the rays of light will be focused in front. Index myopia, it is because of increase in the refractive index of the lens, rays will be focused in front, and the increase in refractive index occurs in nuclear sclerosis and diabetes-induced complicated cataract. Fifth is myopia due to excessive accommodation. In patients with spasm of accommodation, they are going to be myopic. Now, the grading of myopia. According to the American Optometric Association, myopia has been graded into three types. The low myopia is when the error of refraction is less than or equal to 3 diopters. Moderate when the error is between -3 to -6, and we call it a high myopia when the refractive error is more than 6 diopters. Now the clinical varieties of myopia, it is congenital, simple or developmental. Third is pathological or degenerative myopia, and fourth is the acquired or the secondary myopia, which is post-traumatic, post-keratic, drug-induced, and consecutive myopia. That is when you have done a surgery for hypermetropia, but you make the patient myopic. It is known as the consecutive myopia. Now, discussing in details the clinical varieties of myopia, first is the congenital myopia. Now, the congenital myopia is present since birth, but it is usually diagnosed by the age of 2 to 3 years. Anisometropia is usually present because mostly the error is unilateral. High degree of error, about 8 to 10 diopters, is usually there. Then because the patient is not able to see for distance, keeps doing near work. So convergent squint is also seen in patients with congenital myopia. Other congenital anomalies associated in these patients may be a congenital cataract, microphthalmos, aniridia, megalocornea, and congenital separation of retina. Early correction of congenital myopia is desirable. Now, the second variety is a simple myopia. Simple or developmental myopia is the commonest variety. It is considered to be a physiological error not associated with any other disease of the eye. The prevalence is in 20 to 40% of population, and this simple myopia is mostly seen in the school-going age. So it is also known as a school myopia, seen between 8 to 12 years of age. Etiological, it is the normal biological variation in the development of the eye and usually not genetically determined. Axial type of simple myopia will be because of increase in the length. Curvatural is because of underdevelopment of the eyeball, and role of diet in childhood, role of genetics. This is the prevalence of myopia in children with both the parents myopic is 20%, children with one parent myopic 10%, and children with no parent myopic 5% chance. The theory of doing excessive near work in the childhood has also been put forward, but that did not gain much importance. So what will be the clinical features of patients with myopia? The patient will come with the symptoms of poor vision for distance. Asthenopic symptoms, that is pain in the eyes, tiredness, frontal or frontotemporal headache, then half shutting of the eyes. The parents will complain the child closes the eyes, makes a slit of the eyes, and that gives him more clarity. Psychological outcomes, because the patient is not able to see for distance, it is found that such children become more introvert and less interested in the outdoor activities. What are the signs we will see in these patients is a little prominent eyeball. They are typically large and prominent. Anterior chamber is going to be slightly deeper than normal. Pupil somewhat larger and somewhat sluggishly reacting to light. Fundus will be absolutely normal for a myopic patient. Patient of a simple myopia, fundus is normal. Magnitude of refractive error. Simple myopia usually occurs between 5 to 10 years of age and goes on increasing till 18 to 20 years with a rate of minus 0.5 plus minus 0.3 every year. In simple myopia, usually the error is low to moderate and is not going to exceed minus 6 diopters. Diagnosis will be by performing the refraction of the patient. Now, pathological myopia. Pathological myopia or high myopia or degenerative myopia or progressive myopia is a myopia, usually patients having more than minus 6 diopters and usually associated with degenerative changes in the vitreous, choroid and retina. This is less common and seen in only 2% of the population. Now, what is the etiology of the pathological or degenerative or the progressive myopia? In this, the axial length of the eyeball goes on increasing towards the posterior pole. So, because the axial length increases, there is stretching of the sclera. The sclera gets stretched, but choroid, retina, vitreous, they will undergo degeneration. So, in pathological myopia, you will find increased axial length, degeneration of choroid, retina and vitreous. What is the role of hereditary? Certain genetic factors play a major role in the etiology of the progressive myopia. Familial, that it is more common in certain races like Chinese, Japanese, Arabs, Jews. This is uncommon in Negroes, Nubians, Sudanese and more common in women than in men. Role of general growth factor. Lengthening of the posterior segment of the globe commences during the period of active growth and usually ends with the termination of active growth. Therefore, the factors such as nutritional deficiency, certain debilitating diseases, endocrine disturbances, and indifferent general health also influence the progression of the myopia. Then what will be the clinical features, symptoms of these patients? Defective vision, definitely. And these patients are going to have a high myopia, refractive error more than minus 6 diopters. Musky volitantis, which is black floaters, floating black opacities in front of the eye may be complained by some patients. And this is because of degenerative changes in the vitreous, degenerated liquefied vitreous. Night blindness may occur in very high myopes like minus 12, minus 15, minus 16. These very high myopes because of degenerative changes in the periphery of retina. The patient may also complain of night blindness. Now, the signs of a patient with progressive myopia. Prominent eyeballs. Cornea is going to be large, anterior chamber is deep, pupil is large, sluggishly reacting to light. More important, what we see in the progressive pathological myopia are the degenerative changes in the fundus. So you should read the degenerative changes, because the degenerative changes in a pathological myopia is very important from the exam point of view also. So this is because of the stretching of the choroid, the retina, and this the choroid. You can see that is the temporal myopic crescent, Foster Fuchs spots seen in the macula in a patient with the progressive myopia. Optic disc is going to be large and pale, and it has a temporal crescent, which is known as, that is the temporal crescent I showed you in a patient with myopia. And the peripapillary crescent, sometimes it is only in the temporal margin, and sometimes it is all around the disc, where the choroid and retina is distracted away from the disc margin. Degenerative changes in retina and choroid. Chorioretinal atrophic patches at the macula with a little heaping up of the pigment around them. Foster Fuchs spots, which is a dark red circular patch due to subretinal neovascularization and choroidal hemorrhage present at macula. Cystoid degenerations in the periphery. Latest degeneration is thinning of the retina in the periphery. Latest degeneration and or snail track lesions with or without retinal holes, tears may be present, and because of these retinal holes, the patient will be complicated with a rhegmatogenous or a simple retinal detachment. Details, this will be taught to you in the chapter of retina. Then total retinal atrophy may be present in advanced case. Posterior staphyloma, which is because of ectasia of the sclera at the posterior. Degenerative changes in the vitreous, they include liquefaction, vitreous opacities, and posterior vitreous detachment, that is PVD, appears as a Weiss ring. Visual fields may show contraction, and in some cases of very high myopia, ring scotomas may also be seen. ERG reveals a subnormal ERG due to chorioretinal atrophy. Complications: retinal detachment, which is a rhegmatogenous retinal detachment, vitreous hemorrhage, choroidal hemorrhage, a complicated cataract, and primary open angle association of patients with myopia. Now, we come to the treatment of myopia. Optical treatment. You will do the refraction of the patient, and you will prescribe appropriate concave lenses according to the patient refraction, so that the clear image is formed on the retina. What is the basic rule of correcting myopia? The minimal acceptance that provides the maximum vision, that is to be prescribed. In high myopes, somewhat undercorrection is better to avoid the problem of near vision and minification of images. The images for near gets minified, so little undercorrection always is preferred in high myopes. Contact lenses of appropriate power to be given in patients who are usually above 14-15 years of age, who can handle the contact lenses, उसका sterilization उसको कैसे maintain करता है, how to wear them. So this is usually after 14 to 15 years we prefer to give contact lenses. And in patients with high myopia, because of the thick lenses, the patients will have spherical aberrations and chromatic aberrations. There will be peripheral distortion, so contact lenses may be preferred in certain patients with high myopia. Then surgery of myopia, the surgical corrections there. Before dealing with surgical correction, there are certain general measures: a balanced diet rich in vitamins and proteins, early management of any associated debilitating disease, visual hygiene for the asthenopic symptoms, like a proper posture should be there, erect posture, the light should come from behind, proper illumination when you're reading. You should not read when you're lying down. There should be proper clarity of the prints, and continuous reading during night hours should be avoided. it. So proper visual hygiene should be told to these myopic patients. Avoidance of excessive near work for high myo specifically, and you should try to आउटडोर एक्टिविटीज को encourage करना है इन patients में. Then treatment में some preventive measures have come, that is atropine drops in low strength 0.01% instilled at night, and pirenzepine 2% gel applied twice daily. Then, of course, patients with very high myopia, genetic counseling has to be given. Too high myopes should not get married, and if they get married, they should not have children, because then it goes in the children also. Low visual aids in patients with progressive myopia with advanced degenerative fundus changes where useful vision cannot be obtained by spectacles and contact lenses. There, low visual aids may be tried, and surgical correction of myopia has gained popularity. What are the various methods of doing myopia correction surgically? There are cornea-based procedures and lens-based procedures. So first we will deal with is the cornea-based procedures, RK, that is radial keratotomy. Radial keratotomy refers to making deep 90% of the corneal thickness radial incisions, as we can see here in the peripheral part of the cornea. These radial cuts are given customized according to the refractive error of the patient, and the central 4 millimeter of the pupillary zone is always left behind. ये 4 millimeter का pupillary zone को छोड़ देते हैं, उसके बाद में in the periphery these retinal cuts are given, and then when the incision will heal by the flattening, the cornea का curvature flatten हो जाएगा, refractive error है वो improve हो जाएगा. This procedure gives good correction for low to moderate myopia, that is about 2 to 6 diopters of myopia. And however, there is a certain disadvantage because it causes thinning of the cornea. Cornea में especially जो sports खेलते हैं तो उसमें naturally you have given cuts on the cornea, so that weakens the cornea, and there was glare. जो cuts के कारण these patients used to complain of glare photophobia. So now better procedures have come forward. So RK is not recommended present. Disadvantages of RK, I told you the cornea is weakened, so there's chances of globe rupture following trauma are more with RK than with PRK. So it is a risk in sports person, athletes हैं, military person है, they can be uneven, क्योंकि आपने कट लगाए तो वहां पे अगर uneven healing हो गया तो irregular astigmatism हो जाएगा, and there were unpredictable results and development of progressive hypermetropia after decades of surgery. क्योंकि जो कट्स दिए थे उसमें फाइब्रोसिस होता है और बहुत ज्यादा फाइब्रोसिस हो गया तो मायोपिया की जगह हाइपरमेट्रोपिया हो गया कुछ पेशेंट्स को. सो नाउ बेटर procedures have come forward, which are laser ablation corneal procedures. The first of these is PRK, that is the photorefractive keratectomy. In this technique, first the epithelium, you remove the epithelium with the help of either spatula or 20% alcohol or a rotatory spatula. Okay, you will remove the epithelium, and then the central optical zone of the corneal stroma is photoablated with the excimer laser, which is a 193 nanometer UV flash to cause the flattening of the cornea. PRK is a good correction gives good correction for -2 to -6 diopters of myopia. इसमें हम deepithelize करते हैं and then corneal stroma को photoablate करते हैं to cause the flat with the excimer laser. That is the PRK. This is you are doing the deepithelization and then you are doing the flattening of the cornea with the excimer laser. Now the next procedure, corneal based after PRK, is laser in situ keratovolusis, which is LASIK. In this technique, first a flap of 130 to 160 micron thickness of the anterior corneal tissue is raised with the help of an automated microkeratometer. वहां पे हम एपिथेलियम हटा रहे थे पीआरके में with the blade or the spatula or with 20% alcohol. Here with the automated microkeratome we are removing a flap of 130 to 160 micron thickness of anterior corneal tissue. And after creating this corneal flap, mid-stromal tissue is then ablated with the excimer laser beam and ultimately causing the flattening of cornea. That raised flap, ये जो flap आपने raise किया था, is then ultimately put on the cornea. And this is a surgery of choice for myopia up to -8 nanometers. Patient selection for LASIK: patient above 20 years of age, patient having stable refraction for at least 12 months, a motivated patient, patient with absence of corneal pathology and any presence of ectasia, any other corneal pathology or corneal thickness less than 450 millimeters is a absolute contraindication for doing the LASIK. Now there are some advances in LASIK like a customized LASIK, C-LASIK. This is based on doing a corneal topography and a wavelength technology. In addition to spherical and cylindrical correction, it also corrects the aberrations present in the eye, and this customized LASIK gives a very good vision, 6.665 vision it is given. Then what is a femto LASIK? All laser LASIK, no blade LASIK. It is a technique in which the corneal flap, जो कि microkeratome से बना रहे थे, this is made with the help of laser rather than the microkeratome which we were doing in the case of LASIK. You were making the flap, the anterior corneal flap with the help of microkeratome. But in LASIK, that is the all laser LASIK, no blade LASIK or femto LASIK, that flap is also made with the help of laser rather than microkeratome, and it is giving a greater precision and consistency. What is epi-LASIK or E-LASIK? Instead of corneal stromal flap, only the epithelial sheet is removed with the help of a customized device, that is an epikeratome. This is LASIK, C-LASIK, femto and E-LASIK. Advantages of LASIK: minimal or no postoperative pain as compared to PRK, because PRK may we're doing a deepithelialization, so you have to give a contact lens to that patient epithelium and you have to wait for the epithelium to grow, and that sometimes was causing pain to the patient. So the LASIK is giving minimal or no postoperative pain. Recovery of the vision is better as compared to PRK. There is no risk of perforation during surgery and later rupture of globe in patient, unlike the RK. Then no residual haze, unlike PRK where subepithelium scarring sometimes used to occur. Epi and LASIK is effective in correcting myopia up to -8. What are the disadvantages of LASIK? It is more expensive. It requires more surgical skill than PRK. Then there can be flap related complications which are intraoperative flap amputation. Wrinkling of a flap hटाया, laser किया, then you reposit the flap, wrinkling of the flap on reposition. Postoperative flap dislocation, subluxation, epithelialization of the flap bed interface and irregular astigmatism. Other possible complications could be infection, diffuse lamellar keratitis, dry eye, corneal ectasia, glare and regression. Now, the next procedure is refractive lenticule extraction, that is the RELEX procedure, or also known as SMILE, small incision lenticule extraction. इसमें क्या करते हैं? This is also known as all femto laser vision correction refractive lenticule extraction RELEX. इसमें क्या करते हैं? A lenticule, ये lenticule generate करते हैं स्ट्रोमा और फिर एक इंसिजन देके इस लेंटिक्यूल को बाहर निकाल लेते हैं. What we are doing in this is a lenticule, no flap. We're not creating any type of flap here. In this, a lenticule of corneal stroma is first generated. Laser से ही lenticule बनाया जाता है. You're generating this laser and then this lenticule is then removed. This is the you're making the lenticule and then you're removing the lenticule of the corneal stroma is extracted with the help of femto laser. This technique is also known as SMILE, that is a small incision lenticule extraction, and this corrects the astigmatism up to 10 diopters. SMILE received FDA approval on April 2016. Now, the fourth corneal procedure is intercorneal ring implantation, that is ICR. Intercorneal ring implantation into the peripheral cornea at approximately 2/3 of the stromal depth is being considered. This results in the vaulting effect and flattening the cornea, decreasing the myopia. ICR procedure has also the advantage of being reversible, disadvantages, unpredictable results, and causing keratitis. ये rings हैं, they have been implanted 2/3 of the corneal stromal depth में ये दो ICR rings implant करी गई हैं and these rings cause flattening of the cornea and correction of the orthokeratology is a non-surgical reversible method of molding the cornea with overnight wear of unique rigid gas permeable contact lenses. It is considered for the correction of myopia up to -5 diopters and used even in patients below the 18 years of age. Orthokeratology, that is your flattening. This is a non-surgical method. Unique, rigid, gas permeable contact lenses होते हैं. Leave them overnight and they will cause the flattening of the. Now, lens-based procedures. Those were corneal-based procedures. RK, PRK, classic, RELX, and orthokeratology. Now, the lens-based procedures. First is refractive lens exchange. That is, in very high myopes, lens का power क्या होता है? The total power of the eye is plus 60 diopters. उसमें 42 to 44 is the power of the cornea, and plus 16 to 18 या plus 18 to plus 20 is considered the power of the crystalline lens. ठीक है, प्लस है. और अगर पेशेंट को -16 to -18 diopters का हाई मायोपिया है तो जो उसका क्रिस्टलाइन लेंस है, क्लियर लेंस को एक्सट्रैक्ट आउट कर दो तो वो जीरो हो जाएगा. सो दैट वाज व्हाट दे थॉट व्हेन they started the refractive lens exchange, that is the extraction of the clear crystalline lens. Foucault's operation has been advocated long back in myopes of -16 to -18 diopters in a unilateral eye. Recently, clear lens extraction with IOL implantation of appropriate power, that is a refractive lens exchange, has been recommended as a refractive surgery for myopia more than 12 diopters. But as any cataract surgery, this can also have complications of endophthalmitis after cataract and retinal detachment. Other lens-based procedure is a phakic refractive lens or implantable contact lens considered for correction of myopia more than 8 diopters. In this technique, a special type of intraocular lens is implanted in the anterior chamber or posterior chamber anterior to the natural crystalline lens. इसमें crystalline lens नहीं निकाल रहे हैं. Crystalline lens वैसा ही है. In front of the crystalline lens, the normal crystalline lens, you are implanting the IOL. So this is known as an implantable contact lens, IC. The possible complications can be endophthalmitis, iridocyclitis, cataract formation, and secondary glaucoma. You can see here, lens वहाँ पर ही है, and that is the implant behind the cornea and in front of the crystalline lens, whether in the anterior segment or in the posterior segment. Thank you.